So nice to introduce our friend Dr. Chaitanya, who has so many things to his credit. He's done his diploma in pallioscopy from Germany, has been a past president of Nagpur Vijay Society. He's obviously a chairperson of Infertility Committee of AMOGS, and he has been in so many committees and doing hard work. And he is ubiquitous. He's present everywhere, and not only his name is present, but he is present and doing a lot of work in counseling, also taking his sessions in his clinics and everything. So it is my pleasure to introduce you to all of you, Dr. Shembekar. Dr. Shembekar, please. Unmute yourself. Chaitanya, unmute yourself.
So thank you, Sudesh. My regards to uh, Pratik, Rajendra Singh Pardesi sir, Kavita madam, and Dr. Vipin is also there. Uh, I bring greetings from Nagpur OBGYN Society and Infertility Committee of IMOGS and Omega Hospital along with my directors, Dr. Manisha Shembekar, Dr. Paru Savji, and Dr. Ashish Sararia. And my special thanks to Dr. Nandita Bashatkar and Dr. Pratik Tambe for giving me this opportunity. The topic for today's discussion is insulin sensitizers in PCOS. And if you just think about PCOS, I would say that PCOS की कहानी एक लंबी कहानी है, and it starts with adolescence. And that is the reason why we always say that we should catch them young, because we should know what is the meaning of irregular cycles in the initial phases of life. You all know that irregular cycles are so normal in the first year that they are not at all considered as abnormal. But after 1 year, if any one cycle goes beyond 90 days, we call it as irregular cycle. From 1 to 3 years, less than 21 days and more than 45 days is considered as irregular. After 3 years, less than 21 days and more than 35 days is considered as irregular. And if there is no menses or no menarche up to the age of 15 years or 3 years after thalarche, that is also considered as abnormal. So this is something which we all know. But what is important is we should not label a adolescent girl as PCO. There is no hurry. The guidelines clearly say that adolescents with features of PCO but who do not meet diagnostic criteria, they are considered as high risk for PCO, and you have to do reassessment 8 years after menarche, and where the patient has got symptoms of and signs of PCO but they are on OC pills, those who are persistently having features of PCO, and those where there is a abnormal weight gain during adolescence. All these considered as potential candidates for PCO, and you have to reassess the patients 8 years after menarche. This is something which is important. Now, as far as the diagnostic criteria are concerned, there are many criteria which are in use, but we all know, and even 2018 latest guidelines have also endorsed Rotterdam criteria as the best criteria for the diagnosis of PCO, where there is a hyperandrogenism, oligo-ovulation or ovulation disorder, and polycystic ovarian morphology on ultrasound. Any two of these three criteria should be there. Then there is Androgen Excess Society, which has said that hyperandrogenemia is very important and it has to be there along with ovarian dysfunction. And I personally feel that NIH 2012 criteria, which is an extension of Rotterdam criteria, is the most important criteria. Why? Because they have not only considered the features of Rotterdam criteria, that is hyperandrogenism, ovulatory dysfunction, and PCOM, but they have also identified the phenotypes of the PCO. And why these phenotypes are important, I'll just tell you that phenotypes are important because you have to classify the patients depending on their phenotypes. So there are four phenotypes of PCO, phenotype A, B, C, and D. In short, the picture that comes to your in front of your eyes when you think of PCO is phenotype A, which is a classic PCO, which is patient is obese, hirsute, with polycystic ovaries and anovulation and all the features of PCOS. If the ultrasound features are normal, that goes to phenotype B. If the patient is ovulating, but still she is looking like PCO, then she goes to the category C. And if the patient is lean and thin with no hyperandrogenemia but PCO, then she goes to phenotype D. So in short, phenotype C and phenotype D are actually mild varieties, and phenotype A is a classic variety of PCO. Now you have to, and you should not forget ethnicity. Why ethnicity is important? Because the world is small and you may get various patients from various countries, and you should know that the PCO is relatively mild in Caucasians, BMI is high in North American Australians, hirsutism is more severe in Middle East and Mediterranean women. And what is important for all of us is in Southeast Asia, the Asians and the Southeast Asians, especially the Indians, they have central adiposity, insulin resistance, and diabetes with metabolic risk and acanthosis nigricans. These are the classical features of Indian PCO, while East Asians, they have low BMI and mild hirsutism and high BMI and metabolic features in Africans. So we in India fit into this category where insulin resistance and diabetes is very common, and therefore for us today's topic is more relevant. We should actually try to understand the difference between the lean and obese PCO. This is important because, as I told you, classical phenotype A is a obese PCO, but then there are various features which are seen in lean PCO as well. Like if you find out the LH levels, you'll find that LH levels are high in lean PCO. Androgen excess and hyperandrogenemia is more in obese PCO, but it is less in lean PCO.
हाँ, बोलो.
Hyperinsulinemia is more in obese PCO but less in lean PCO. Insulin resistance again is more in obese PCO but it is less in lean PCO. Now, why I'm telling you this is because hyperinsulinemia and insulin resistance are seen in lean PCO as well, but the features are less severe as compared to the obese PCO. That means here one thing is clear: whenever we are treating the patients for insulin resistance and hyperinsulinemia, you have to consider lean PCO as well. It is not that metformin should be given only in obese patients, because hyperinsulinemia and insulin resistance both is seen in lean PCO, but the severity is less as compared to the obese PCO. Then there is, of course, androgen levels are high, hypertension, uh, impaired glucose tolerance, diabetes mellitus, and endometrial hyperplasia all are more commonly seen in obese PCO as compared to lean PCO, but still all these features are also seen in lean PCO. This is something which we all should know. Now, the diagnosis of PCO is very clear: clinical hyperandrogenism, biochemical hyperandrogenism, and ultrasound features. Clinically, there are various features of hyperandrogenism, like there is a, you take the history and examination, you find that the patient has acne, alopecia, hirsutism. Hirsutism is calculated by modified Feynman-Galloway scoring. Ludwig scoring is used for alopecia. There is no scoring system for acne, but acanthosis nigricans is something which is seen in more than 50% of patients in obese PCO, especially in Indians. Now, whenever we are taking the history and doing examination, you have to think about the psychological aspects of clinical hyperandrogenism as well, because these are the patients who are frustrated and they are, they are fed up of this acne, they are fed up of obesity, hyperandrogenism, and you have to take care of their psychological aspects also. So you have to tell them that this is something which will go if you take the treatment properly, and don't worry about them, because body shaming is something which is really worrisome for many of these girls, and especially the adolescent girls. Then biochemical hyperandrogenism is always there for diagnosis. We do the testosterone free androgen index, DHEA, and we also do the test for the infertility, which include FSH, LH, prolactin, and TSH and AMH. The most important thing is the test for hyperinsulinemia. And what are the tests for hyperinsulinemia? You should remember this point, that regardless of age, the risk of impaired GTT and type 2 diabetes and even gestational diabetes is very high in PCO, and it is seen five-fold in Asians where we live. In India, it is 5 times more common. The risk is exacerbated by obesity, and the test which is done is OGTT, fasting glucose, and HbA1c. And whenever we are doing this test, you should do the lipid profile as well, because if the patient is having obesity, then you have to do lipid profile as well. Now, where is the role of fasting insulin? And the guidelines, the latest guidelines say that fasting insulin is not included in the investigations. What is important is OGTT, BMI more than 25 and BMI more than 23 in Asians, family history of diabetes, family history of PCO, hypertension, ethnicity in Indians, gestational diabetes, always go for OGTT. Even if the patient is planning for conception, pre-conception investigation should include OGTT as a investigation of choice in these patients to rule out the possibility of diabetes and the PCO. The pathophysiology of PCO is very clear. Here the patient has got hyperinsulinemia, abnormal ovulation, and hypergonadotrophism. And as you can see, the hyperinsulinemia and insulin resistance is something which is really worrisome, and we are discussing this today as far as the treatment is concerned. So in treatment of PCO, you can categorize the patient into two categories. One is adolescent girls and the patients who do not need treatment for infertility. And the second category is the patients who need treatment for infertility. And insulin sensitizers are the drugs which are used in both the categories. Whatever may be the category, whatever may be the situation, lifestyle modification is something which comes first, and it plays a very important role. So you should ask the patient to go for weight loss, which is the first line treatment in overweight patients. Truncal obesity is something which is important. Waist to hip ratio is something which is important. Even 5% reduction in the weight is going to make a big difference. And so ask them, do not ask them to come back by reducing 30 kg weight or 40 kg weight. It is not possible. What you have to tell them is you start reducing 2 kg per month, something which is possible and feasible, and 5% weight reduction is also going to help them in ovulation, spontaneous ovulation, and maybe conception. And they have to, you have to take care of their stress and tell them about exercise as well as diet. Now, as I told you, both the situation, insulin sensitizers are important. We find out what is the role of these insulin sensitizers. Insulin sensitizers, they increase the sensitivity of insulin towards the receptors, thereby decreasing hyperinsulinemia. That is how they work. And women with PCO may have a defect in the secondary messengers contributing to the insulin resistance. So this is how the insulin resistance happens in the patients with PCO. And the most popular drug of all is, of course, metformin. Metformin is an oral biogonide. It lowers blood sugar level in type 2 diabetes. Therefore, it is a treatment of choice in type 2 diabetes. It does not have effect on glucose in normal subject. If the sugar levels are normal, it will not have any effect and it will not lead to hypoglycemia. What is the mechanism of action? It inhibits hepatic glucose production, improves peripheral glucose uptake, reduces absorption of glucose, reduces serum lipid levels, thereby reducing substrate availability, and helps in gluconeogenesis. Dosage of metformin is 500 milligram per day to start with. It has to be given orally, and you have to increase the dose gradually. The maximum dose is 1500 milligram per day. You can give it in the dose of 850 milligram BD or 500 milligram TDS, depending on the situation. Now, this is something which is interesting. The latest American Diabetes Association, ADA, has given 2021 guidelines, and these guidelines are interesting, and I would like to have inputs from the experts who are there along with me today. They say that this is a category B drug, and therefore it is not a first line treatment, and you should stop the treatment once the patient conceives, and stop it after first trimester if the patient has got PCO. So you have to stop the treatment after first trimester. This is something which is given by ADA. It crosses the placenta and cord levels of metformin are high. If you do 4-year follow-up, you'll find that the babies have got high BMI. There is no benefit as far as prevention of abortion is concerned, and it is a potential for growth retardation in babies. Therefore, it should not be used if the patient is having PIH and IUGR along with the diabetes or GDM. So when to give metformin? You can give metformin when the insulin is not giving, insulin is not possible, and you have to do counseling and you have to tell the patients that insulin is the drug of choice in gestational diabetes. And even if the patient has got PCO and you are giving metformin to this patient, you should stop this after first trimester in PCO. This is something which we all should know. Now, metformin is known to cause many side effects, and most of them, 45% of them, they are gastrointestinal side effects like indigestion, heartburn, vomiting, bloating, pain in abdomen, and diarrhea. Patients may have headache, and the fatal complication is lactic acidosis, which is a rare complication, but it is fatal. It is very commonly seen when the patient has got renal diseases. So the contraindications for this drug are renal diseases where the creatinine levels are more than 1.4, cardiac failure patients, patients having sepsis, patients who are using IV contrast, patients who are having liver diseases, metabolic acidosis, and alcoholism. These are the patients where you should not give metformin. So metformin has got various advantages. It leads to weight reduction, it decreases hyperinsulinemia, it reduces androgen levels, restores ovulation. High pregnancy rate and live birth rate is also high, and it is a first line medication for metabolic manifestation such as hyperglycemia, which is very commonly seen in the Asian patients with PCOS. Now, what do guidelines say? It is very interesting to find out what the guidelines say. 2018 PCO guidelines, which are used, we are using these guidelines nowadays. These are the latest guidelines. They say that for use of metformin, it is said that in non-infertility patients, it is found that insulin resistance is seen in 75% of lean PCO and 95% of the obese PCO. And therefore, you can use metformin in both lean as well as obese PCO. That is something which I was telling you initially. And many countries, they are using this metformin as an off-label drug, but still you can use it because most of the endocrinologists, they prefer this drug and the benefits are much more, and therefore you should use it even if it is off-label. Treatment, the key question for the guidelines says that is metformin alone or in combination effective for the management of hormonal and clinical PCOS features and weight reduction in adolescents and adults with PCOS. So this is the non-infertility treatment, and the guidelines are very clear. It is said that metformin in addition to lifestyle should be recommended in adult women with PCOS for the treatment of weight reduction, hormonal and metabolic outcomes. It should be given if the BMI is more than 25 in other countries, and in Asians more than 23 BMI. Metformin should be given in adolescents with clear diagnosis of PCOS, and metformin may be offered if the patient has got high risk of metabolic disorders, and especially in high risk ethnic groups like Asians. You can use and you should use metformin if there is a high risk of diabetes and impaired glucose tolerance and also ethnicity. Some important points. Adverse effects of metformin are important, and therefore you should discuss these adverse effects when before starting the metformin. You have to start with a low dose. Always start with 500 milligram per day and increase the dose every 1 to 2 weekly, and better to use extended release tablet because it will minimize the side effects. The important point is long-term use of metformin, and this is the question which is asked by many of us in many of the webinars and conferences, that how long you can give metformin. The guidelines say that metformin use appears safe long term, so you can give it for more than 3 months. Initially it was said that you should give it for 3 months, but here the point which is important is there is a low B12 levels associated with the metformin use, and therefore whenever the patient has got this, we are using this for long term basis, you have to give a supplement B12 along with the metformin. So there is overall benefit of metformin which favors the use of metformin, and the side effects are self-limiting. Metformin and fertility. As we know that PCO means anovulation, anovulation means PCO. And the drug of choice for the treatment of anovulation in PCO is letrozole. It is not clomiphene citrate. Mind well, the new guidelines say that letrozole is the drug of choice for the treatment of PCOS in ovulation induction. And CC comes as a second line treatment, and metformin also comes as a second line, and alone it is not a very good drug, but it is good drug as an addition. So whenever the patient does not respond to letrozole, you can do various things, like you can give HCG to the patient, you can give dexamethasone to the patient, you can give pre-treatment with OCBs, and you can give adjuvants. So what are the adjuvants which are important? The metformin is the most important adjuvant, and another adjuvant which we are discussing today is anositol. So metformin is something which is actually a hero of adjuvant. So adjuvant का hero कौन है? तो बेशक metformin है, क्योंकि metformin is a drug which is known to have an important role in the ovulation induction, and it can be given for long-term use as well. Now the key question is, can you use metformin along with clomiphene citrate? Does it improve outcome in patients with BMI more than 32? And the answer or recommendations to this is clomiphene citrate is the first line drug. It is better than metformin. But if the patient is not responding to clomiphene citrate, then you can combine clomiphene citrate with metformin. And one more guideline says that whenever the patients are obese with more than 30 BMI, metformin can be used for ovulation induction along with clomiphene citrate. So you have to combine these drugs, and the combination is very important. It works wonders. So the if you just look at the stepwise treatment of the PCO, you will find that after the basic ovulation induction drugs like letrozole or clomiphene citrate, the step before HMG, that is gonadotropin injection, is metformin. And CC and metformin is a combination which is better in CC resistant patients, the patients who are not responding to letrozole and CC. And this is a combination which is less expensive and more convenient. So you all can take the screenshot of this algorithm. Why? Because this algorithm is important in the management of PCOS. Here you will find that in the first step of the treatment, before going to the next level of treatment, you try letrozole first. No response, you go to gonadotropins. But before going to gonadotropins, in between the letrozole and gonadotropin comes the role of metformin. So metformin is actually a treatment before going to the level 2, that is gonadotropin. So you can actually give gonadotropins, but before that try metformin for a for some cycles. Now the advantage of metformin is that it works as a very good cocktail. It blends well with many drugs, like as I told you, letrozole, clomiphene citrate. Not only that, it works and blends well with gonadotropins as well. So you can try this drug even with gonadotropins. That is the advantage. And these are the guidelines about the role of metformin in IVF and ICSI patients. It is said that in agonist protocol, you can use metformin as an adjuvant, and it reduces the risk of OHSS, and it is a very good drug to improve the clinical pregnancy rate. It is said that whenever we are combining the gonadotropins with metformin in agonist protocol, you should start it 1 month before treatment or at the start of GnRH agonist treatment. You should give dose between 1000 milligram to 2550 milligram daily. So that is what guidelines say. 2550 milligram per day is the maximum dose. You should stop metformin as the pregnancy test becomes positive, and the metformin side effect should be counseled to the patients. Not only agonist, even in antagonist protocol, it is said that metformin combination along with gonadotropins works well and prevents OHSS and improves pregnancy rate. So that is the advantage of adjuvant metformin in the patients of IVF and ICSI. So one thing is very clear, metformin is here to stay, and we can and we should give metformin to all our patients. Now, what about the other drugs? The less popular drugs, which personally I must tell you here that I have never tried this drug. They are rosiglitazone, pioglitazone, and troglitazone, which is now not available in the market and not used. But the rosiglitazone and pioglitazone are known to have GI intolerance, hepatic toxicity, heart failure. It is a category C drug, therefore cannot be given during pregnancy, and therefore these are the drugs which are not very popular. So then what is the next treatment which is available? If the metformin patient is not tolerating metformin, or if you wish to give something in addition to metformin, a new ray of hope is inositol, because inositol is a drug which inositol both produces as well as activates PI3 kinase. Inositol acts as a precursor for PI3 kinase, and therefore it's a new ray of hope. Now, there are two types of inositols which are available. They belong to vitamin B complex group. So it is nothing but a vitamin B complex. Myoinositol and D-chiroinositol are the two drugs which are available, and they help in improving the fertility. So this is how they act, and this combination works very well because the myoinositol works on the ovary while D-chiroinositol works peripherally. Myoinositol reduces hyperandrogenemia, regularizes the cycle. Spontaneous ovulation takes place and improves ovarian response. Nuclear and cytoplasmic maturation is also there, and it also improves the oocyte competence. Peripherally, D-chiroinositol acts, reduces insulin resistance, improves glucose metabolism, and improves lipid profile as well. Therefore, this is a win-win combination. This combination is going to help you in many ways at the ovarian level as well as at the peripheral level. Now, this is a combination which is available in the combination of 40:1. And it is said almost all the studies have confirmed that 40:1 is the best combination and the dose is 2 to 4 grams per day. Now the key question as far as the guidelines are concerned is myo-inositol alone or in combination with other therapies effective for the management of hormonal and clinical PCOS features and weight reduction in adolescents and adult with PCOS? So these are the non-fertility situations. Can we use this drug in adolescent girls or obesity patients with PCOS who are not interested in conception? It is said that the clinical need for the question is because mostly treated patients are treated with metformin and glitazones. Their side effects are more. Inositol and D-inositol is a nutritional supplement, therefore, and also acts as a second messenger. It plays a role in insulin signaling transduction. So summary of systematic reviews evidences say that Cochrane has compared inositol with placebo and they found that SHBG levels are favorable to inositol. So SHBG levels are favorable in inositol, but there is no difference between myo-inositol and placebo in BMI, waist to hip ratio, ovulation, then cholesterol, fasting glucose, fasting insulin level. So there is no much difference between these. But the
Dr.
narrative review
Chaitanya,
evidence,
just
yes.
5 minutes to go, sir.
Okay, 5 minutes to go. Okay, I'll finish. I'll wind up. Okay. But the narrative recent review evidences say that ovulation rate and menstrual cycle rates are improved with myo-inositol. And some studies, they say that it also decreases the risk of GDM. And therefore, not only this, it also helps in the treatment of hirsutism. And there is 16 to 30% reduction in hirsutism. So considering all this, the recommendations are very clear. Recommendations say that inositol should be currently considered as an experimental therapy, but you should encourage using this drug because it is having good effects. And justification for this recommendation is that there is emerging data which says that metabolic, hormonal, and ovulatory benefits of myo-inositol are more. It is freely available, it is cheap, and has got limited side effect. Therefore, it should be considered as a drug for the treatment of PCOS. So, in short, myo-inositol and D-inositol are here to stay, and they are also going to have its effect in the fertility treatment as well. It improves the oocyte quality, embryo quality, improves menstrual cycles, improves fertilization rate, and also pregnancy rate. Now, as we have discussed metformin and we have discussed myo-inositol D-inositol combination, can we use both the drugs in the treatment of fertility? The answer is yes. You can use the combination for the reduction of body weight and also in the treatment of fertility, because this combination together is going to help our patients for ovulation induction as well as for improving the pregnancy rate. There is one more drug, that is N-acetylcysteine, which is actually a insulin sensitizer, which is a antioxidant, and it is a drug which is also a very good drug which prevent follicular atresia, improves pregnancy rate, lowers androgen level, and provides immune support to the patients. And there is a study which says that N-acetylcysteine and myo-inositol combination improves ovulation rate and also helps in the pregnancy and also regularization of menses. And therefore, you can give it in pregnancy as well as non-pregnancy indication or non-conception indication. Last but not the least is the vitamin D3. Vitamin D3, as we all know, is a very important molecule, and almost 45 to 90% of the women are deficient in vitamin D3. And therefore, if you add vitamin D3 to this combination, this is going to help you in many ways. It helps in PCOS, with insulin resistance. It helps in ovulatory dysfunction. It stabilizes hormone levels, improves insulin resistance, and helps in maintenance of ovarian reserve and decreases androgen levels. Therefore, vitamin D is also a drug which can be added to this combination. So the take-home message is very clear. PCOS is very common disorder. We are actually treating PCO patients day in and day out, adolescents से लेकर के सी endometrium तक, infertility से लेकर के irregular cycles तक, we are treating these patients in our clinic day to day. Lifestyle modification is something which we tell to all our patients. Metformin is the drug of choice in addition to the other treatment. Myo-inositol D-inositol combination can be added to the metformin along with N-acetylcysteine and vitamin D. So thank you very much for patient listening, and special thanks to Dr. Pratik Tambe for giving me this opportunity. I'll stop here, end here. Thank you very much. Thank you.